Thank you. I appreciate it. Good morning. I'm going to try to go over what I have done for about, I guess, what am I, 36 years out of training, and spent my career with some amazing people. One of them was someone who's probably my closest friend, George Searney. And then when George, right before he passed, he said to me, Dave, I'm passing the torch to you. Don't let it burn out. Luckily, now at UCSF, I have two young guys who I'm training to pass the torch to, and the subject of bone infections and chronic infection especially, which is a whole different animal. And that's what I want to get across to you today, that it has to be thought of as a different animal. And it matters the way you think, and you have to understand the microbes, because the only way to beat the microbe is to understand it. And I literally can teach my residents and the young attendings I'm working with now that the patient's body is often telling you what the microbe's saying. You just got to stand back, examine the patient, and pay attention. Over the years, this kind of broke down my practice. 50% is pure osteomyelitis, and 30, well, maybe 35% non-unions. Of the non-unions, though, at least half are infected. So it means literally 2 out of every 3 patients I see has some sort of bone infection in reality. And it's a unique practice. I don't know anyone else who has that in North America. It developed over the years, whether I wanted it or not, I guess. So it's allowed me a wide perspective, nowhere near what George could do. George could document the care of somewhere between 3,200 and 3,400 cases of osteomyelitis. I really don't feel that will ever be repeated again. One of the things I'm going to push, and this really matters, and every year it's very clear it matters more and more, intravenous antibiotics. What is their role in the treatment of chronic osteomyelitis? What is the backing, the data that backs their prolonged usage, and do they then work? And let's jump into that in a funny way. First thing I'll ask all of you is what percent of your patients at your institution are discharged with a PICC line or some other method for delivery of chronic intravenous antibiotics if they're diagnosed as osteomyelitis? And anyone can jump in, but I will tell you, after giving variants of this talk for quite a number of years, the vast majority of people and places always seem to say somewhere in this high number of 100% or 75 to 99%. And I will tell you the correct number is way below this last number, and I'm going to try to show you why. Looking at history, chronic osteomyelitis, when I was a resident, had a cure rate at best of somewhere around 12%. But probably the major reason is we didn't understand the basic science of it. We didn't understand, nor did anyone, that there are different stages of an infection. In other words, the phase of growth of the microbe itself, and then the construction of a biofilm, which was not described until way more recently by Bill Costerton. And this data was a game changer. So the data for giving chronic intravenous antibiotics was level 4 data for acute osteomyelitis in the pediatric population of 6 weeks, where it seemed to work. So there were no other reasonable options. The problem is the answer was wrong. And when I was in medical school, I remember being taught that somewhere between 2/3 and 70% of everything I'm going to get taught in 15 or 20 years will be wrong. This is another example of it. It is. That's why you always have to stay current and educated and not sit back on your heels. What we're going to look at is a battle between prokaryotes, the bacterial form of microbes, and us, eukaryotes. But my question is this really a battle? In many ways, we're just a biosphere for microbes. If you look at the number of bacterial cells to our cells, they have us outnumbered by about 10 to 1. If you look at the number of viruses to bacteria in our body, there's about 10 times more viruses than bacteria in our body, our biosphere for them. Gives a ratio of viral particles of 100 to 1. If you look at number of microbial genes then between viruses and bacteria, it's roughly 400 microbial genes for each human gene in our body. I'll tell you right now, this is a fight we can't win by fighting them. We have to accept that they are an integral part of us for survival as well. In fact, it's gone further. My old friend Jay Parvizi has finally bought onto the idea, which I strongly endorse and feel strongly is true, that we have a microbiome in all parts of our body, including our joints. We have a natural microbiome in them and have to exist with it. Looking at other animal species, this is just to give you an idea of how little we know about our world. This was done about 2 years ago. This study was published in Current Biology, and they went into the South Pacific and out of the deep ocean harvested just bugs, just growth, different kinds of growth, not microbes, but just animal creatures, small animal creatures. And it was funny. What they found was about 5,500 animal species they recorded, and 90% of those that they obtained just by doing this were completely unknown to science before this. This is how little understanding we have just of animal species, albeit small animal species, on our planet. Over time, the estimates of bacteria that we can currently culture on Earth were revised. And of these choices, it's a simple question. What percent of microbes on Earth, bacteria on Earth, can we currently culture in a medical lab? Well, actually, the old number accepted by microbiologists, not doctors, but PhDs, not medical doctors, it was 7%. About 8 to 10 years ago, they revised that to 1%. If the public knew how little we understand about bacteria, I think they'd be quite worried, astonished. But we can only culture a small percent of microbes on Earth. So something that grows that looks like an infection, but is culture negative, that doesn't mean much. George and I, in our past, ran about somewhere around 40 to 50% of cases of chronic osteo were culture negative, but clearly an infection. Looking at Nature Communications, they found something to kind of back that from 2 years ago. They took a sampling of 99 coral reefs from the South Pacific with about 6,000 samplings done, looking for the microbiomes in this reef, and they analyzed for bacteria via DNA analysis. And from the extrapolated sample size, they determined the ocean alone had harbored about 2.8 million varieties of bacteria. Until 2 years ago, this was the total estimated number of species of bacteria throughout the planet. So we have really no idea how many species of bacteria exist whatsoever on this planet. So the 400 microbial genes that we believe, from what we know, exist for every one of our genes in our biosphere, quite frankly, is probably far from comprehending the number of this, and I wouldn't be surprised if it's double this or more. So once again, to beat microbes, we have to first understand them. It's that simple. And that's what I've spent my career in. Lab I've had at Stanford now for the last 15 years. It's run by Derek Montola, who has it now, and I worked with in the past. And with time, we're starting to understand them a little better and a little better and a little better. Establishment of infection occurs over time. How long does it take for a mature biofilm to form? We really don't know the answer to that. But it's really clear that a biofilm forms over a certain amount of time after some initial inoculum. And what happens is the initial microbes, they die. Then those are the privates. Then the corporals come in, they die. Then the sergeants, then the lieutenants. Then with a certain material set, the brass comes in and builds this microbiome with the colonels and the captains and the rest into this very mature three-dimensional chemical structure, all the while simultaneously the cell line of the prokaryotes, the planktonic cell line, changes and gets smaller, changes into a small colony variant, then eventually the sessile phase of growth. The biofilm itself is this organized matrix of DNA, proteins, and polysaccharides. Sounds like dead microbes, right? That's what it is. And what they construct is a very hydrophobic three-dimensional structure. Why this is important is antibiotics we deliver, be it orally or intravenously, are dissolved in, for the most part, usually saline, and can't get into and penetrate such a hydrophobic structure. This represents one of the strong barriers, and the problem with much of the work being published in the literature, it's done in vitro, and what they present is their results on destroying, quote, biofilm on a culture grown on a plate after 48 to 72 hours. First of all, those aren't sessile phase of growth. They are the small colony variants, and there is no biofilm there to give the protective coating. So I warn you, when you read the literature and read studies done like this, you are going to see that 90% of them, roughly, don't represent reality. In fact, over the last 2 years, I found 3 in American JBJS alone. And the data they extrapolate, you can't do. So the editors of JBJS don't understand this subject matter, quite frankly. And this is a little scary. So read this very carefully, everything you read. And if it comes out as being just on a plate after 48 to 72 hours, don't let them talk to you about being a biofilm. It is not true. How long does it take to form? Well, the truth is nobody knows, but probably it's about 15 days. The way to do this is clear. You need a flow chamber with confocal microscopy. It's all doable, but it's moderately expensive. And no one's ever sat down and taken the time to do it. It's a bit involved. And every time I thought I could get it off the ground, I unfortunately didn't have the resources, but hope to, hopefully in the near future, but it is a bit expensive. Biofilm maturation. This is a really difficult subject matter. Why it matters is when you have a full mature biofilm, we know that intravenous antibiotics don't do a thing because you need 1,000-fold an MIC to work even against the fully sessile phase of growth. And how long does that take to happen, and when's it a mature biofilm? Huge question. What we do know is there is an evolution where they change and behave differently. And that first change is to the small colony variants, which then, when they can get in a biofilm, develop into the sessile phase of growth. So we can't say when does an antibiotic stop working, but all we can do is hypothesize this right now. And it's sad that we have such a poor understanding of a mature biofilm colony. I just don't think enough resources are being put towards this. So what matters is the infection still in the planktonic cell phase of growth where antibiotics do work. That's what they were designed to work on. Pneumonias, cellulitis, things like that. Or, in fact, are they a mature biofilm like this picture shows with the sessile bacteria poking through the slime and looking around. So, the bacterial phase of growth, planktonic versus the mature sessile phase of growth in a biofilm. Difference, planktonic cell line represents the initial inoculum phase. The bacteria have a high metabolic rate, and they are free-floating. The biofilm phase, this represents the semi-dormant bacterial phase, where the microbe is trying to live. This is important in a symbiotic state with the host. They don't want the fight. They don't want to destroy their own home. They just want to get along. They have a very low metabolic rate. They're adherent in the biofilm, and they're 10 to the third times less sensitive to most antibiotics, but possibly one. Their low metabolic rate is such that in the planktonic phase of growth, they multiply somewhere between every 30 to 60 minutes. In the biofilm, the generational cycle is about 24 hours. So intravenous antibiotics, what is their role in chronic osteomyelitis? George tried to study this, and he did, in fact, back in the late 80s, early 90s. He did a retrospective prospective study. He took a study of those that had up to 2 weeks of intravenous antibiotics versus those that had 6 weeks or more of intravenous antibiotics. Every case was done by a single surgeon, him, and there were about 400 patients in each treatment arm. The results, no difference in outcome, with a trend toward better outcome in the shorter antibiotic group, because you were poisoning the patients less and destroying their gut microbiome much less. The gut microbiome and proper nutrition are really very important to be able to fight an infection. So in fact, we're doing these patients a disservice with chronic intravenous antibiotics, I believe. He could never get this published. It was too controversial, and journals refused to publish it. I promised him before he passed that I would get it published. His wife got me most of the data, but not all. She passed 6 months later, and I could never get enough of the data cleanly to get it published despite having a journal willing to do it. So I decided to repeat it. We published this in 2019 in Injury and looked at this very subject. I did this with Malcolm DeBon, who's one of my residents. I think he's the director of orthopedic trauma at Duke now. And Gina Suh, who is one of the infectious disease doctors I trained. She's now at the Mayo Clinic as the chief of musculoskeletal infectious disease. We looked at 164 cases of chronic osteo I treated between 2012 and 2017. We didn't include type C hosts. I exclude 4 cases of coccidiomycosis because in those they required chronic antibiotic suppression for pulmonary involvement, so it wasn't clean, pure osteomyelitis. 17 cases of failed TKAs who we did knee pseudofusions on because they had been given more chronic courses of intravenous antibiotics. We had 7 lost to follow-up of that 164. There were another 9 that were para quadriplegics. And I don't think they're fair to look at because they are chronically put on antibiotics for UTIs and other infections. We wanted pure, isolated, chronic osteomyelitis cases only to see what would happen. The breakdown of the patients, nothing surprising. The Serenity Monitor classification, I think it's really important that every case of osteo, the chronic osteo you see, you classify it. I don't feel you can treat the infection without this. I can tell you 98% of docs out there do not classify it or understand it. That's the reason they have such poor results in curing it. It matters because the classification determines the treatment method. Here's the breakdown. No surprise. Stage 2s, I debated with George whether they even exist, and the bulk are stage 3s and stage 4s. The host type, this is very important. What's the health of the host? Locally and systemically, this matters. You have to maximize the health of the host for good treatment. Where the infection exists, no surprises here. And our treatment algorithm, I've used this treatment algorithm for at least 30 years. It hasn't changed. I haven't found a way to improve on it, unfortunately, but you have to go down the 4 steps and make sure each step is covered before you go to the next. If you skip a step, your chances of failure increase dramatically, I found. I've always believed in the liberal use of free tissue transfers, but I was jaded. My associate for many years was Harry Bunke. Harry is known as the father of microsurgery. He invented the free flap, and I was very lucky to always have great access to its use. And excuse me, still believe if there's a soft tissue defect of any kind, free flap is your friend, and don't be afraid to use it. And in fact, 30% of these patients did require a free flap and benefited directly from it. 7 patients out of those got some form of chronic IV antibiotics. My rate is way less than that now. Just since 2019 or 17, the rates dropped down to about 1%. I've had 2 patients in the last 5 years get any form of long-term IV antibiotic. One of those was a woman with just pure isolated femoral osteo, stage 3. The reason she got it is she was an engineer and she was crazy, insisted on it, and I refused, and the ID doc agreed. She got pancytopenia from the IV antibiotic and got very sick and had to stop. The other was a patient recently for a strange eukaryotic infection of mucor. Mucor is very aggressive, and I will give that maybe in that one instance it was necessary. Of the 5 in the study I'm presenting that got chronic, of the 7, the reason for it was 5 had some form of significant autoimmune disease, be it lupus, rheumatoid arthritis, or Still's disease with significant immunosuppression, and the other 2, one had cancer and the other cirrhosis. I'm not sure cancer and cirrhosis are an indication anymore. There were 2 recurrences at 2 years. Both were my fault. I improperly staged the patient as a stage 3 osteo when they were a stage 4. One of those I took back, treated as a stage 4. He did fine without any problems. The other had femoral involvement, was not a candidate for a bone transport of that large segment, and underwent an AKA. I did have one other patient at 3 years that presented with swelling and erythema and did get better spontaneously. Because of that, I assumed it was an infection, but I'm not sure it was or wasn't. And it resolved, I think, with a short course of oral antibiotics. I'm not sure, but I want to report it to be thorough. Again, a low incidence of failure with about a 98% roughly cure rate. Here's an early example from way before this, from 1993, because I want to show you how things haven't changed that much once we developed a method that works. Obviously, there have been changes, but they're small. 25-year-old with a motorcycle accident, grade 3A open right distal tibia fracture, fibula. Was treated in an outside facility. You can see the date of October of 1993. He was treated by a surgeon in a small community hospital who saw an ad for the Ilizarov method and fixator in the JBJS and decided to try it. The surgeon did an acute shortening of 8 centimeters and a partial fibulectomy with a proximal tibia corticotomy. It wasn't really a corticotomy, but more of a stripping of periosteum 2. This was all very aggressive and done at the initial IND. And here he is, this patient, just insanity. But, you know, by the x-ray, oh, it doesn't look so bad, huh? But really quite crazy. What happened is when you shorten a leg acutely like this, you get arterial or kinking, and the soft tissue envelope necroses. And here is the family taking pictures of his leg slowly necrosing. So that killed another 7.5 centimeters of soft tissue and bone. So now he has a defect of about 15.5 centimeters, with 8 centimeters being in the shortening. And that's candida growing on the bone. And at this stage, he was transferred to me. This is a tough problem. We obviously offered him amputation, but he had a sensate foot, was in good health, and he had some intact plantar and dorsiflexion. So we decided to proceed with treatment at his request. But this was back in '93, considered pretty experimental, a flap and transport at once. I did take a lot of questioning by my peers in this. Here he is, wide debridement, get back to healthy bone, healthy soft tissue. He got a large latissimus, which we don't have to do as often anymore. We explored the corticotomy. The periosteum was stripped, so I just held it tight, did nothing for a month, and actually compressed it a little and tried to create some callus to do really a calotasis. Here he is, we're moving him downhill on the railroad tracks, growing bone behind it. You'll notice now the frame gets changed to a lengthening frame, where we're lengthening the limb now as we've done the transport. Here he is after about 14 months, the frame's removed with 15.5 centimeters of new bone. Here's what his leg looked like at about 4 months after the frame was removed. Here's his x-rays 6 months post-frame removal. He went back to dental school now, was in dental school again, trying to finish up.
The video here on the right is him
in our clinic
following frame removal.
UCSF when I was
and you can see his function at this time. He went on to graduate dental school, worked as a dentist in Las Vegas, retired in Reno. He skis recreationally now. He has no pain or limitation. And I talk to him by phone, just like the prior patient, because they don't see me anymore because they're just fine. But they're doing quite well with this method of treatment. And you can see how predictably functional these people are.
So this was him at 6 months. He sent me this 28 years post-op. After the frame removal, they skied, had no pain or limitation. Then he finally sent me this, I think a year ago, roughly, this last year. Just out of the blue, he emailed me this, that he put together of himself. So I do believe that we have the technology and tools, and we can show long-term results of it, that saving limbs is beneficial when it can be done safely and effectively. Back in 1996, we first published a large series on the combined bone transport and free tissue transfer, showing 36 cases with follow-up. With time, more publications appeared, and we published more on this, and the doubters slowly became believers, where initially this was considered a bit of heresy. Then in 2015, 127 cases of bone and tissue defects treated with free tissue transfer and bone transport. Only 3 patients underwent late amputation. And we found actually our main reason for failure was psychosocial issues, of them losing medical support, them losing insurance, them losing their place to live, etc. I've done definitely over 160 cases of combined bone transport and free tissue transfer to this date and time, with the same quite good outcome. Some heresy, further heresy, and read this for a sec. The specifics of the microbe mean the species. Is it Staph aureus? Is it Staph epi? Is it Pseudomonas? These things is less important than the specifics or condition of the host. This sounds crazy, but I'll show you that there's data to back this up. This was a study done by my friend Tracy Watson, and what it was trying to show was a method they came up with for the treatment of open fractures gave better results. And it was simply patient comes in, culture them, wait 48, do a washout, wait 48 hours, something grows, take them back to the OR, repeat to breed it, and culture it, and then wait another 48 hours. Once you get culture negative at 48 hours, back to the OR and definitive closure. They did not look at what the specifics of the microbe was, nothing. All they cared about, did something grow at 48 hours? And when they did that, their outcome was much improved with much less failure after wound closure. A very simple idea, but it worked. What that was showing is nothing about the microbe. It was showing that you've created a living wound, George's term, not mine, a healthy wound that was living, that could support being closed because its own natural immunity now was healthy. So, an important concept, get a healthy wound. That's what's key. When you read papers that it really matters that you get a wound closed early, we found that to be absolutely not true. What mattered is creating a living, healthy wound. Our results were no different on wounds that came to us that were 6 weeks old, 8 weeks old, 10 weeks old. What we did is got a living, healthy wound, then flapped it, and our results were the same as if we had flapped those within a couple days. No difference in outcome. That's why it's so important, I say, to do what George insisted, which was he had the staging system of the bone and a staging system of the host. And this has to be done on every patient because there are many patients with severe infection, systemic compromise, and other problems where a limb salvage is more dangerous than letting the patient live with the degree of disease from the infection he or she has, or suppressive treatment or amputation. So it's really important to do this as well and stage the patient. Some more heresy. I then realized, based on this, that we came up with something called the 3-microbe theorem. And all that mattered to us was not the microspecifics of the individual microbe, but what was the preponderance of the microbe? Was it mainly prokaryotic, the infection, mycobacterial, or fungal, eukaryotic? And once we defined that, it helped us define the treatment a little more accurately. Breaking it down further than that, our infectious disease docs who worked with me on all these cases found no difference in outcome. And I strongly believe that's the case. I still see this around, but can't believe it, that people still profess the benefits of hyperbaric oxygen for chronic osteomyelitis. There is really no data to support this whatsoever in vivo. And this paper, I thought, put the nail in the coffin on it from 13 years ago out of USC. They showed it did not help at all, and in some ways actually helped the microbes grow better. So I urge you not to put any faith in hyperbaric oxygen. It's a waste of resources and time. So what works? Thorough debridement, local dead space management, local antibiotic delivery at a ridiculously high concentration. There's been data on and off about possible vaccines. We're not there yet, maybe in the future. Phage therapy, I really thought would pan out. I have to say, we had research grants on it. And I have given up on phage therapy. I think it's a panacea, and there are too many problems with it currently that I don't see this making it into the wide spectrum, certainly any time in the near future. What doesn't work? IV antibiotics alone do not work. Hyperbaric oxygen does not work. Wound care centers do not treat the problem, and most other garbage. It's those 4 stages of treatment I showed you. Those are the only things that definitively work right now in chronic osteomyelitis. What's sterile? Good question, huh? I was taught in medical school 0.45 micron filtration was sterile. Probably terminal gamma irradiation is. 0.22 micron filtration? Actually, probably not. There's new data to show that there's a form of life called ultra-small microbes that can pass through a 0.22 micron millipore filter. They're facultative, but have now been implicated in certain disease states. So when we think we've sterile filtered something, we're fooling ourselves. That's not really sterile. I'm presuming terminal irradiation is, though, but that might be it. The sinus tract. This is another crazy idea of mine, I will admit. Do you leave it or excise it? I was taught to excise it. I did for a long time. And now I only excise it if it's in the surgical wound that I have to make. And I'll tell you why. The sinus tract's your friend. It's telling you how your treatment did. It's your barometer of the body. So I leave them when I can because it tells me if my treatment's working. Such an example, a person with multiple sinus tracts, I think he had 4 or 5. I left the medial side ones. We weren't going through there. And it told me that he was being cured and working. So I urge you to understand that. Listen to the body. It's trying to talk to you. Here's a woman with probably the longest osteo I'd ever seen in a patient, a 79-year-old who developed new onset of a drained sinus tract after getting the flu. She first had osteomyelitis at age 15. It was of her distal femur. It was hematogenious. She underwent excision and debridement. She was one of the first patients in the States to receive penicillin on a compassionate use basis. She had a debridement of it. They thought it was complete, but this was done in the, I believe, 40s at the time. And she did fine until 7 weeks before I saw her, which was about 10, 12 years ago. And the flu just kicked in a sinus tract again. And that's very interesting that I've seen this time and time again, where a viral infection can ruin the equilibrium between that microbe living in harmony with the host and it breaking away and shedding planktonic cells. So she did. She shed planktonic cells. Here was her x-ray. I can actually see part of the walling off process here and the sequestrum right here in her, which did fine for 60 years, over 60 years, 64. There's the sinus tract that developed. I had to excise this one. It was in the surgical field that I was making. Craterizing with rounded edges the bone, so it was a stage 3. There's the sequestrum right in there. You can see it. They're real. Size of the bone window. The sequestrum once it's removed. And then an antibiotic bridge plate. Very high dose local antibiotic. Use that to bridge it. No reason to ruin the endosteal blood supply up and down with an antibiotic nail. I see this all the time where doctors have one form of treatment, antibiotic nail for everything. It's absolutely the wrong thing to do. Antibiotic nails are for stage 1 osteomyelitis. That's why I say you stage the treatment to the stage of the osteo. Here she is with filling the defect created with local antibiotic bead delivery and a spanning antibiotic bridge plate for stage 3 osteo. Remove it after 6 weeks or so, culture negative. I use another bridge plate, antibiotic bridge plate, but graft the defect with bone. I always try to use some autograft and iliac crest. 5 months, 1.5 years. And I only was able to communicate with her after this by telephone because she had to come from too far a distance, and said, I'm fine. And I'll let you know if it changes. And I kept in contact with her about 5 years before she passed away, but never with recurrence. 32-year-old female, status post high-speed motor vehicle accident, found laying in a riverbed after 8 hours. She was treated with a rod. It became infected. She was treated in casts and developed chronic draining osteomyelitis, draining, I think Pseudomonas in her case was what it was. And I can't remember if there was some aspergillosis as well. So they couldn't stop the antibiotics because all the antibiotics were doing was suppressing it. But as soon as they stopped, multiple sinus tracts developed, and here she is. You can see an abscess developing here with the osteomyelitic bone here. She has stage 4 osteo, had to do a wide excision, span it with a fixator, and use the fixator for transport, but like to transport over a nail of sorts. So here's the nail that was put in once we had her infection under complete control. We're using the transport very carefully, just unicortical pins to move the bone down and complete a 10-centimeter transport. It's always tough then to get them to heal here. We took the frame off. She didn't heal the docking site, and that's what happens. And that's easy. You can fix that once you have enough mature bone here with various methods. We had grafted it first, but it still didn't heal. She had nonunion at the grafting site. But if you let that mature a while, just wait. This did fine with just an exchange rodding with internal grafting by reaming. And she went on to heal nicely. She never had recurrence. She got back to work and just been leading a normal life. I do still hear from her. The last time was several years ago, and that was at 22 years follow-up. She had no limitation in function or activity, took no pain meds, and led a normal life from what could have been a really devastating outcome. So the proper treatment of osteomyelitis, chronic osteo, by staging it, getting the correct treatment, no use of chronic intravenous antibiotics. They do not have a role. You can really help these people. Another final example, 38-year-old male, motorcycle accident. I really owe my career and reputation to the motorcycle. It's been very good to me. He had a segmental open tibia and fibula. It was treated at a community hospital in far northern California with a washout closure and intramedullary rotting. He developed about 6 sinus tracts in his leg. The doc said that was normal, don't worry. But after 6 months, he became a little nervous and said, I want to send you to the world expert. It was true. He referred him to my friend George, who was in San Diego. The only problem is I can tell you, since I wrote his obituary, that George died 2 days before the referral. And George's wife was still living and referred him up to me. And we took care of him. And the patient presented with these x-rays. But this drives me crazy. The residents always look at the x-rays first. I tell them the last thing you want to look at first is the x-rays. Look at the patient in general. Look at the leg. Do it systematically. And here's the way his leg looks. This was a Morel lesion of the leg. It sheared the soft tissue off. He had sinus tract here, 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 with this terrible soft tissue envelope. But he had a sensate foot. He could put weight on his leg. His ankle worked. So this is a tough problem. What do you want to do? I would not fault anyone for going straight to amputation. It's not a failure of care. If you see someone, they have a terrible problem, you tell them you need an amputation and you do it. That's not failure. What failure is seeing them trying for a year to save their leg, having that fail, then doing an amputation. So you ask yourself, what do you want to try here? I think there are many options, but not many good options. And I would say it's the first one, I would never fault, and the last one. I don't think the masquerade has a real role here. I think its role is limited. So back to the 4-step program. That's what we did. Did not change from that. Climb the non-union ladder. So the first thing we did, cleaned up the wounds, took out all the dead bone. At this level, it was a stage 4. For the whole tibia, it had a stage 1 component because it had a rod in chronically. So there was obviously some spread up and down the rod. Down at the distal tibia, about a half of the circumference of the tibia was alive when we explored it and healthy. We did not take that out. We put beads in the part we did take out to fill the dead space, but left a good 50% of this tibial segment. Then waited to make sure there was no recurrent infection and started doing a bone transport, moving the upper segment down to fill this. Did that. Here we are starting the transport. Here's the transport going as far as we can before we impale onto this segment and letting that mature. Just simply waiting. Once the bone filled in adequately up above, take the frame off. Now what we have is no evidence of infection, no sinus tracts, a straight leg that's the same length as the other, with failure of healing here and here. We could have tried to do a whole diaphyseal transport, but that's a little much and not necessary. No reason to do this. So at this point, we have a living wound, living bone, improved soft tissue envelope with a segmental non-infected non-union. Climbing the ladder, took him to the OR and did a free fibula from the contralateral side with grafting above and below. And you always take these on a skin paddle because it's your barometer to tell you the bone's alive, because the blood flow to the skin goes through the bone and out. We did that. Here he is at 3 months. Here he is at 6 months. He's walking normally and he's gone back to work now. Here's the clinical of his leg. This is the skin pedicle from the flap. And see how the rest of the tissue gets healthier when there's no infection and no inflammation. This is the way his leg looked at this point. His x-rays at 10 months. He's working now 40-hour weeks as a trucker at this point. Here's him in clinic.
Yeah, and then just turn around and go back.
Most people wouldn't be able to pick which leg it was. Three years, working 50 hours a week, doing everything. In fact, he bragged to me he's doing so well, he bought a motorcycle again. Here's his photographs of his leg at 3 years. And I'd call him, but he refused to come in. He'd say to me, this is a quote, "Doc, I'm fine. I can do everything. Got a new motorcycle. I don't need you anymore." And continued to work. So the treatment algorithm works, and what we can do is we can show long-term outcome with many, many cases of long-term outcome, because I've been doing this since 1989. Why this all matters. How much antibiotic do we consume in the United States? This is 12-year-old data now. No, 11-year-old data now. I'm sorry, but no one's ever reported back on it. Anyone want to take a guess how much we consume in powdered form? Well, I'll tell you. It's down here. 51 tons of powdered antibiotic a day are consumed in the US. If you look at us by population, we are low users. Third world countries are double our use. Countries, especially India, is probably the biggest consumer of antibiotic usage because antibiotics have gotten cheaper. This is equates to this much we're dumping into our biosphere. This is data that was determined by the London School of Hygiene and Tropical Medicine, probably the finest institution in the world in epidemiology. that 5 years from now, we'll be dumping 105,600 tons of antibiotic into our biosphere per year, which equates to 290 tons a day. This is a scary, scary figure. We are going to poison ourselves if we continue like this. The London School and the CDC, before it turned into what it is now, unfortunately, with our current fearless leader, has projected that the leading cause of death in the world will not be tetanus, cholera, measles, trauma, dysentery, diabetes, or cancer, but death due to antimicrobial resistant infections. So us dumping all this into the environment is us poisoning ourselves and will certainly lead to our eventual demise. If that doesn't convince you, watch this.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, porous and thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic. It spreads until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. Then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
11 days. Scary, huh? Questions I always get asked: DNA sequencing. It's usually PCR sequencing with the 16S ribosome. We've had mixed results. I think it will be the future. Unfortunately, next generation sequencing in all of them, there's a problem with the way they process it. And we have had really significant failures where they're not giving even as good a results as good culturing techniques. So I just think we're not there yet. It's going to take more time, unfortunately. Breaking down hardware retention versus removal for early versus late infection. I think this is an easy answer, to be honest. And you see all these, I have given for 3 years now, fracture-related infection, ICL, at the Academy meeting. I've been on the panel, and I think it's a waste of time, so I think that you can answer that subject with one slide, and this is it. If the infection is chronic, with a Searney Mater stage 1 or 2, you can often maintain the implant, suppress it until healing, then remove the metal and any osteomyelitic bone. I think that's a very reasonable treatment option. Obviously, you have to discern whether it's early versus late, though. But the lates are different. So for late chronics with stage 1 or 2, if you want, you can retain it. But if it's a stage 3 or 4, you're really just kicking the can down the road, and this is going to resurface. So why not deal with it early and not put the patient through 2 sets of trauma and torture? That's it. I always honor the people who were before me. Of my teachers, only one's currently still living. And I want to thank you for your time. I'm happy to answer any questions.